We can give people about 2 minutes to join.
Hey, how are you, Jeff?
Hi, Jeff. How are you?
Thank you. How are you?
Good.
Hey, Alicia.
Hi, Jeff.
So from Robert's 15, I can see probably twice as far as I could 2 hours ago. In terms of smoke reporting.
All right, Jeff, you can start.
Unmuted. Okay, welcome everybody. Thank you for joining. We've got 42 participants. I'd like to especially thank Dr. Alicia Alcamo, our presenter today. And I'll do a brief intro and then Alicia will take it away. Would you advance, Ari? First, a few announcements. On June 22nd, Dr. Jenna Reese from Pathology will present as well. So we're looking forward to that. Hope that you all can join. Next. CME credit. CHOP Pen physicians, please contact Mark Diltz. Next. And hold your questions. Anything you have that you are comfortable, please put in the chat. And most likely we'll address at the end of the presentation. If something really burning comes up, I may interrupt and ask Alicia to address a question that came up. But for the most part, she won't be looking at them. I'll be moderating at the end. Please mute. Looks like just about everybody's muted at this point, and there are live captions available. Next. Again, pleased to have us be joined today by Dr. Alicia Alcamo, attending physician at CHOP. Dr. Alcamo attained her BS in biology from Elizabethtown and had her first exposure to scientific research, participated in a bunch of experiences that got her going on research, process and design. And then in medical school at Ohio State, she combined her medical degree with an MPH, Master's in Public Health, specializing in clinical and translational science, and completed residency and chief residency at Cincinnati Children's Hospital. We were then fortunate enough to have her come to CHOP for pediatric critical care medicine under an NIH T32 scholarship in neurointensive care. Fellowship at Pittsburgh, and then joined CHOP's Division of Critical Care Medicine in 2019 as an attending physician. I'm sorry about the fellowship flub. I met Alicia, I want to say 4 years ago now. It was face-to-face, so it was in the before times. And she was scratching her head thinking about how to launch a research project in building off of the sepsis work that had happened in Arcus. And it was a very typical of CHOP, she navigated to DBHi and ARCUS by word of mouth, and we ended up introducing her to the ARCUS program at a time when it was relatively new and nascent, but she went and ran with the resources and has been quite successful in publishing and applying for grants. She has a K under review right now, which is we're hopeful that for a positive outcome there, and has a bunch of great science that she's going to share today. So harnessing data from the EHR, electronic health record, to understand acute brain dysfunction in pediatric sepsis. Take it away, Alicia.
Thanks so much, Jeff, for that introduction. Just pulling up my slides. All right. Thank you for this opportunity to talk today. I'm really excited to share the work that I've done with ARCUS with everyone here. So for this talk, I will first start by providing some background on pediatric sepsis, and we will discuss some associated challenges with studying sepsis within the EHR. Then we will discuss what acute brain dysfunction is, and then we'll start to talk about what are the challenges with not only defining acute brain dysfunction, but then studying acute brain dysfunction in the electronic health record. We will end by discussing how I have leveraged the EHR data in ARCUS to study acute brain dysfunction and where I plan to go with my future work. As Jeff started to allude to throughout this talk, I'm actually going to highlight what my journey has been navigating EHR data and working with ARCUS for those trainees or junior faculty members that might be interested in starting to launch their research career with ARCUS. So for those of you that don't know, sepsis is defined as a dysregulated immune response to an infection that leads to organ dysfunction and organ failure. Pediatric sepsis is a significant public health problem. Worldwide, infection is the leading cause of child death. When we look specifically in the United States, there's an estimated 75,000 children who are develop and are treated for sepsis annually. In pediatric intensive care units, sepsis is the leading cause of death, with mortality rates ranging between 8 and 10%. There are some studies that actually report even higher rates of mortality. But with that baseline 8 to 10%, we estimate that there's 7,500 children who die every year from sepsis. Unfortunately, sepsis survivors experience significant morbidities. Here, I'm going to name a few. More than 1 in 3 survivors have cognitive impairment or report difficulties with school. 1 in 3 survivors have reduction in overall health-related quality of life. And 1 in 5 survivors are readmitted to the hospital at least once within 30 to 90 days after their initial admission. These are significant morbidities, and we need to consider what this means for the children that we take care of every day. I'm going to look specifically now at CHOP data. So this data looks over an 8-year time period. You see from 2011 to 2018. To orient you to the figure, the y-axis on the left here looks at sepsis incidence, and the y-axis on the right looks at hospital mortality. I first want to draw your attention to the orange line. The orange line shows the trends of sepsis incidence for admissions over this 8-year time period. As you can see, the number of sepsis admissions are on the rise. Now look at the green line. The green line shows that the trend for hospital mortality. As you can see, despite the increasing number of sepsis admissions, the overall mortality rate for sepsis has remained consistent at 8%. So although the mortality rate has not changed, this data suggests that we have more sepsis survivors who are at risk for experience significant post-sepsis morbidity. So future sepsis work really needs to not only focus on reducing mortality, but also reducing morbidity. When we evaluate pediatric sepsis and pediatric sepsis mortality, we really focus on cumulative organ dysfunction. So previous studies have shown that cumulative organ dysfunction is a significant risk for mortality in children with sepsis. Let's look at this first figure. The x-axis is the Pediatric Logistic Organ Dysfunction Score, or the PLOD score. This is a common score that we use within intensive care studies that measures cumulative organ dysfunction. The y-axis is the hazard ratio for mortality. The line here that's represented by the squares looks at patients who have septic shock. So these are patients with severe sepsis that have cardiovascular dysfunction and need vasoactive medications. The line indicated by the triangles are patients with severe sepsis. For both septic shock and severe sepsis, this figure shows that as the PLOD score rises, there is an increasing hazards for mortality. So as there's a higher cumulative organ dysfunction, there's a higher hazards for mortality. This second figure kind of drives home this point. This figure comes from a large international point prevalence study of severe sepsis. On the y-axis, you see the frequency or the proportion of hospital mortality, and you see that the probability of mortality increases with increasing number of organ dysfunctions. The investigators of that multi-center international point prevalence study then asked the question, we know that cumulative organ dysfunction is significant for mortality, but does it differ based on the type of organ dysfunction that's present? This table that I'm showing you now breaks down the odds for death based on not only the type of organ dysfunction, but also the timing. So these second and third columns, this looks at the odds of death for patients who had that specific organ dysfunction within the first 7 days of sepsis recognition. So any time within those first 7 days. The last two columns look at the odds of death for those patients that presented with this specific organ dysfunction on the day of sepsis recognition. All right, this is an acute brain dysfunction talk, so let's look at the neurologic dysfunction. You can see that 15% of patients developed neurologic dysfunction anytime during sepsis. For that first odds ratio, for children who had brain dysfunction anytime during the first 7 days, they had a 4.6-fold increased odds of death compared to children who did not have neurologic dysfunction. And if we look at the odds of death for those that presented with acute brain dysfunction, those patients had a 3.8-fold increased odds of death compared to children who did not have neurologic dysfunction. I was really interested in understanding, was there a difference in regards to outcomes based on the timing of the onset of the acute brain dysfunction? So when I first came to CHOP, I performed actually a secondary analysis of this study under the mentorship of Julie Fitzgerald and Scott Weiss. In this figure, I show you 3 different cohorts. So first, those patients that did not have neurologic dysfunction at all during their sepsis admission. So that's that lower bar. The middle bar being the patients that presented with neurologic dysfunction at sepsis recognition. And then the top bar being those patients who developed neurologic dysfunction after the first day of sepsis. We looked at several different outcomes. You can see death as being the black portions of the bar. And then for the survivors, we looked at those survivors that developed new, moderate, or mild disability as the darker gray bars, or who had no new disability at discharge. As I've highlighted, I'm interested in both what happens to kids who die, but also what happens to kids that survive. And so my primary outcome when I started to evaluate this data was actually looking at children that either died or had new moderate disability. So I performed a multivariable logistic regression analysis, first looking at children with no neurologic dysfunction compared to any neurologic dysfunction, so took away the timing aspect. And I found that there was a statistically higher increased risk of death or moderate disability at discharge for those children who had neurologic dysfunction. But now my primary question was the timing. So I first started looking at the children who presented with acute brain dysfunction. As you can see, children who had neurologic dysfunction at the time of sepsis recognition had a 4.9-fold higher odds of death or moderate disability at discharge compared to those with no neurologic dysfunction. If you look at the children who developed neurologic dysfunction after sepsis onset, the odds of death or moderate disability increased to 10.7-fold when compared to the no neurologic dysfunction. Although on post-hoc analysis, we failed to identify a difference between these adjusted odds ratios for death or new moderate disability, as you can see, both of those odds ratios have very large confidence intervals. And it's the fact that they have wide confidence intervals that suggests that potentially there is a difference there and that we were just underpowered to detect the difference between the groups. This is a common problem in pediatric studies, the concerns with having a small sample size. Therefore, since I wanted to explore this question further, I knew I needed to harness a larger sample size. And that's when I went to Jeff and Marianne in the thoughts of, can I use ARCUS and the EHR data sets to evaluate this? So before we talk about challenges with evaluating acute brain dysfunction in electronic health record, we first need to go back to challenges associated with evaluating pediatric sepsis in electronic health record. So first, administrative diagnosis codes are not reliable to identify a cohort of patients with sepsis. Another issue is that defining sepsis has many complexities. First, early signs of sepsis and septic shock are nonspecific and can be reflective of other disease processes. In pediatrics, we also have to consider age, and there's age-specific considerations to evaluating vital signs or laboratory values that are included in sepsis definitions. And then third is we have a significant heterogeneity in our patient population, and they present with different presentations of organ dysfunctions. And last, the thing to consider too is that the determining timing of sepsis onset is very hard, and it's difficult to use the EHR data to actually elucidate that. You can think about the child who presents to the emergency room and is admitted to our ICU with sepsis. They presented to the emergency room because there was a problem and sepsis started before presentation. So we really cannot define the true onset time of sepsis in the electronic health record. Despite these challenges, there is a need to leverage EHR data to study sepsis. In fact, the CDC had called for the need to evaluate sepsis in the EHR. They called for the need for a surveillance definition for quality improvement and quality assessment, really so that we can monitor programs that focus on sepsis prevention, target early recognition, and improve treatment protocols. Most importantly, at least for my purposes, EHR data allows for large population-based studies. So now EHR data could allow researchers to overcome the limitations of having a small sample size that facilitates the studies having enough power to actually evaluate the associations that we want to study. So to address this problem, several members from ARCUS, including Jeff Pennington, Marianne Chaluti, and Joy Payton, joined leaders of the Pediatric Sepsis Program, Julie Fitzgerald, Fran Balamuth, and Scott Weiss, to create, develop, validate an electronic sepsis definition for pediatrics. I want to talk a little bit about what is actually included in this definition and talk through specific things to understand about it. So first, the definition hinges on two components. One, the presence of infection, and two, the presence of an acute organ dysfunction. So the goal of this definition is to identify children with severe sepsis. As you can see, infection is defined by the presence of a blood culture plus administration of antibiotics for at least 4 days. There's obviously some additional caveats there, but I'm not talking specifically about this cohort in length more than this, so that's for another talk. Then there's the presence of at least one organ dysfunction, either cardiovascular, respiratory, hematological, or kidney. It's important to note that there is no acute brain dysfunction included within this definition. We will soon talk a little bit more about why this is the case. This pediatric sepsis registry now is an ARCUS cohort, and just looking at the years from 2011 to 2021, this cohort includes over 5,000 patients. These patients all have at least one sepsis episode, although there's many patients that unfortunately we admit over and over with recurrent sepsis episodes. And there's over 8,000 sepsis episodes during this time frame. So as you can imagine, the size and magnitude of this registry really allows for us to study pediatric sepsis in a meaningful way. Okay, so to transition to acute brain dysfunction now. Acute brain dysfunction in pediatric sepsis is actually on a spectrum. So clinical presentations will range from confusion and agitation to maybe seizures or delirium, all the way to encephalopathy and coma. Despite the fact that we see clinically that patients with sepsis have acute brain dysfunction all the time, there is actually no accepted clinical definition that defines acute brain dysfunction in pediatric sepsis. So, how do the current studies look at acute brain dysfunction and how do they define it? So, these current definitions actually depend on the Glasgow-Coma scale score. And this score was initially developed to assess the level of brain injury in adult patients with trauma. The Glasgow Coma Scale score, or GCS, has now been extrapolated to other critical illnesses without validation within those. So, although it's been extrapolated to be used to define acute brain dysfunction for sepsis studies, there's no studies that actually validate that. As you can see in this table, the GCS score evaluates a patient's brain function in 3 different categories: eye-opening, verbal responses, and motor responses. A patient receives a score for each of these categories, and then those scores are added up and you receive a total score. It's the total score for which the definitions are dependent on, and a total score can range between 3, which indicates there's no eye-opening, there is no verbal responses, and there's no motor response, to a max score of 15, which is what I hope you all have right now, which is that all your responses are present. So let's take an example. I want you to imagine a pediatric patient who's come into the emergency room and will be admitted to our ICU with sepsis. This patient is nonverbal at baseline, has cerebral palsy, and has limited motor capabilities. This patient's baseline GCS may range anywhere from 9 to 10 up to 11 to 13. And it really just depends on the level of their baseline deficits. Therefore, even if the patient clinically on exam does not have evidence of new acute brain dysfunction, because of their baseline GCS score, this would classify them as having acute brain dysfunction in studies if we just look at the number. The reason why this is extremely important is that 1/3 of our population, at a minimum, that we treat in the hospital with sepsis have very complex comorbidities that result in a baseline GCS that's less than 15. You can also imagine a situation for our critically ill patients, our patients that require mechanical ventilation and are intubated with continuous sedation and neuromuscular blockade. These children, because they're intubated with sedation and neuromuscular blockade, you can't measure their eye opening or their verbal response. You can see that notation of NT, non-testable. So you can't even quantify a GCS score. Lastly, when GCS is recorded and documented for a patient in the medical record by our bedside nurses, what we ask them to record is actually the value that is the best obtained during their time period for their evaluation. So imagine a patient with delirium who has this waxing and waning periods of being confused or being appropriate. If they are appropriately responding and not confused, what will be recorded is a GCS of 15, a normal GCS. And this is counterintuitive to my desire to actually be able to identify these patients that have brain dysfunction. So I want to bring us back to that clinical spectrum of acute brain dysfunction. And let's look at what happens with GCS, just to hammer it home. Changes in GCS will most likely capture these very severe presentations of acute brain dysfunction. Someone's encephalopathic, they will have a low GCS, even if they have a low baseline GCS. Yet, there are many of these presentations that are transient, or such as delirium, or just very mild, and they might not have a change in GCS that is going to actually identify them as having acute brain dysfunction. Therefore, using GCS to define acute brain dysfunction leads to selection and misclassification bias in our studies. I just want to highlight further issues with studying acute brain dysfunction in electronic health record. And just to hammer home some of the points, problems with the GCS score. GCS is a crude measure, not developed or validated for pediatric sepsis. GCS does not capture severe presentations, or it does capture severe presentation, but does not capture those mild or transient presentations of brain dysfunction. And it's confounded in children with developmental comorbidities where their baseline GCS score may not be 15, and in children that are critically ill. Most importantly, GCS is not reliably recorded in the electronic health record. Only 50 to 60% of our patients have a GCS recorded within the first few days of sepsis. This limits the ability for us to identify acute brain dysfunction in almost half of the patients that would be included in a sepsis study from the electronic health record. Now, hopefully you can see why that pediatric sepsis definition excluded GCS or excluded acute brain dysfunction as in their definition. And this isn't just a pediatric problem. The adult EHR sepsis surveillance definitions also exclude brain dysfunction because of the missing data associated with GCS. So I'm going to take a step back and talk briefly about some of the work that I did during my NIH T32 fellowship at the University of Pittsburgh. There, I developed a computational phenotype to identify acute brain dysfunction following solid organ and abdominal transplantation. This patient population is at increased risk of having both neurologic and behavioral dysfunction due to exposures to immunosuppressants as well as transplant-related factors. After my fellowship, I joined faculty at CHOP, as Jeff mentioned, and my career goal is to study acute brain dysfunction in all pediatric critical illness. I decided to begin my work in pediatric sepsis because although current data suggests brain dysfunction is common and associated with poor outcomes, this data is limited due to the small sample sizes of these studies and the issues with defining acute brain dysfunction, as I've been talking about. I also want to mention that our current sepsis treatment guidelines omit recommendations for prevention or treatment of acute brain dysfunction. Therefore, I felt work in pediatric sepsis could have a significant impact on the care for the children that we take care of. So, as Jeff mentioned, with these goals, my research mentors, Scott Weiss, Julie Fitzgerald, connected me with both Jeff and Marianne Chaluti, and I proposed that I would iterate and validate the acute brain dysfunction computational phenotype I originally created in Pittsburgh in the pediatric sepsis registry. We talked about my prior work, we talked about my goals, and then they paired me with one of the data analysts, Greg Barron, who has now worked with me for the last 4 years, side by side, and has been very influential for many parts of the work that I've done. For those of you that are interested in potentially getting started working with ARCUS, I also just want to talk about, as Jeff alluded to, some of the other supports that I received. From the beginning, there was help with kind of ensuring my IRB contained all the appropriate data regulations. And then there was countless educational sessions for data manipulation and data cleaning. And that's just some of the support that I received. There's many people who have helped me over the last 4 years. So now let's talk about the computational phenotype. The computational phenotype uses routine data elements that are found in an electronic health record to codify both acute neurologic and behavioral changes from a patient's baseline based on measuring clinicians' actions. So a clinician is concerned about a new neurologic event. Typically, things that we would do would be ordering neuroimaging, such as brain MRI or head CT, ordering an electroencephalogram or an EEG, or potentially administering an antipsychotic medication. So, to have acute brain dysfunction, patients need to have just one of these data elements. They can have more than one, but they just need at least one. And to comment specifically about the neuroimaging and the EEG, this phenotype does not depend on abnormal results. It just requires that the patient has completed the test. This is because prior studies have shown that patients with acute brain dysfunction during sepsis can have normal imaging and EEG findings. This is the final computational phenotype that I'm showing you here. This was after several periods of iteration and also validation. I will note that this phenotype is different from the phenotype that I created in Pittsburgh. The goal of our iteration and validation that we performed at CHOP was to focus on generalizability of the computational phenotype to other institutions and also generalizability to other patient populations. Therefore, when we did the iterations, we focused on including data elements that were not institution specific, and we found that we had to remove some data elements from the original phenotype in order to meet those goals. In order to assess the performance of the computational phenotype, we created a reference standard. This reference standard was created by two different reviewers who performed a manual chart review and looked for documented concerns in the medical record of acute brain dysfunction by the treating providers. We a priori made a list of what those documented acute brain dysfunction concerns may be, included things like altered mental status, new seizures, delirium, that spectrum that I've already shown you. Once that was completed, we compared the reference standard to the computational phenotype. And as you can see, the computational phenotype had a high sensitivity and specificity, sensitivity of 83% and specificity of 93%. It also had a high positive predictive value and negative predictive value to identify acute brain dysfunction, so 83% and 93%. To take this one step further, we wanted to compare the performance of the computational phenotype to those other organ dysfunction definitions that are based on the GCS score. And as you can see, before I explain this, the ARCUS-derived computational phenotype was superior to the other GCS-based definition. I do want to highlight, yes, we had a lot of missing data for GCS, just as I've explained before. And so for this study, we assumed that if a GCS score was missing, it was either normal or no change from baseline. Therefore, a missing GCS score was recorded as no evidence of acute brain dysfunction for this analysis. This is the similar assumption that we actually make for the acute brain dysfunction computational phenotype. If a patient does not have one of those data elements, there's no clinician concern for acute brain dysfunction. So just as we did with the computational phenotype, we compared the performance of the GCS-based definitions to the reference standard in order to obtain sensitivity and specificity. We then compared those sensitivity and specificities for each of the definitions to the computational phenotype. So looking at the table, you can see that the computational phenotype had a higher sensitivity to detect acute brain dysfunction compared to the three definitions we evaluated. And then the computational phenotype had was more specific than both the Goldstein and the Podium, but had a relatively similar specificity to the Prue definition. As part of this validation, we actually applied this phenotype to a validation cohort. So this is a slightly smaller cohort in this time period, but this was what we termed our validation cohort. The validation cohort includes just the first and index sepsis admission for each patient from 2011 to 2019. So you see we started with 33,762 patients. 35% of patients had acute brain dysfunction per our computational phenotype. As anticipated, we detected a higher prevalence of acute brain dysfunction compared to the previous literature reports of 10 to 20% that was based on those GCS definitions. We are clearly identifying that wider spectrum of acute brain dysfunction with the computational phenotype. Then when we look at patients that require the ICU admission, it's not surprising that many sepsis patients require the ICU, although there is a higher proportion of patients who require an ICU admission who do have acute brain dysfunction. Next, we looked at some demographic and clinical characteristics of patients with and without acute brain dysfunction during pediatric sepsis. We found that there was a higher proportion of patients with acute brain dysfunction during pediatric sepsis that had a pre-existing neurologic comorbidity. If you look at the total number of pre-existing comorbidities, patients with acute brain dysfunction during sepsis are more likely to have more than one pre-existing comorbidity prior to sepsis. And then when you look at the number of non-neurologic organ dysfunction on the day of sepsis recognition, you see that children who had acute brain dysfunction during sepsis were more likely to have more than one non-neurologic organ dysfunction. These findings are consistent with the known characteristics of both adult and pediatric sepsis patients that have acute brain dysfunction during sepsis, and it was just a further example of how we validated our phenotype. Next, we looked at outcomes. So we looked at hospital mortality and the need for inpatient rehabilitation as a surrogate for morbidity. You can see those 19% of children with acute brain dysfunction during sepsis died, compared to only 3% of patients without acute brain dysfunction during sepsis. And then 9% of patients with acute brain dysfunction required inpatient rehabilitation. This is looking at just survivors, compared to only 1% of patients who did not have acute brain dysfunction during sepsis. And although this is an unadjusted analysis, we found that there was a 7-fold higher odds of death and a 9.6-fold higher odds of needing inpatient rehabilitation for those patients that have acute brain dysfunction compared to those without. We are now currently working on adjusted analyses to evaluate this association further, and we're specifically looking at the role of acute brain dysfunction on the causal pathway between sepsis and worse outcomes. So what are my next steps in this journey? As Jeff mentioned, I have submitted my NIH K23 application, and it's under review. My K23 includes my first aim is that causal inference analysis for association of acute brain dysfunction with mortality and sepsis. My second aim, I'm interested in evaluating both cognitive and physical functioning morbidity in survivors. So I'm currently enrolling in a prospective study that evaluates both cognitive and physical functioning outcomes up to 6 months after hospital discharge. I'm obviously interested in whether or not children with acute brain dysfunction during sepsis have worse outcomes. I measure cognitive and physical functioning with a set of questionnaires. Parents will complete questionnaires during hospital admission, and this reflects the patient's baseline prior to hospitalization. And then parents complete the same questionnaires at 1, 3, and 6 months after discharge. If the child is old enough, we also have the child complete questionnaires during the follow-up period. In order to evaluate if there's presence of acute brain dysfunction, I plan to actually link my prospective data to the existing electronic health record data in ARCUS. And then I will be able to basically identify acute brain dysfunction using my computational phenotype in a retrospective manner. My hope is also that as I link the EHR data to this prospective data, I'll actually be able to evaluate these prospective this morbidity evaluation in greater depth. Further, I want to explore potential risk factors for acute brain dysfunction. So for the last aim of my K23, I've proposed to evaluate the association of anticholinergic exposure burden to the risk of acute brain dysfunction and outcomes. The reason I've chosen this is because in previous studies of critical illness, high anticholinergic exposure burden has been linked to both mortality as well as delirium. And I already have told you that delirium is a form of acute brain dysfunction. Therefore, anticholinergic exposure burden has biologic plausibility as a potential modifiable risk factor for sepsis. So in this table, I've shown you some common medications that we use to treat sepsis. And many of these medications, whether they be antimicrobials, sedatives, steroids, have these unanticipated anticholinergic effects. Each medication has a level of anticholinergic effects. Some medications have none. Some medications have a significant amount of anticholinergic properties. So anticholinergic exposure can be measured using previous validated measures that have been defined in the literature. There are 2 that I'll be looking at, but I'm going to focus today on the anticholinergic drug scale, or the ADS. The ADS score ranges from 0 to 3. 0 represents no anticholinergic activity, and 3 represents a significant amount of anticholinergic properties. Many of the medications that I have now shown you in this table have scores of 1 or 2. So for studies, patients are given a total daily score to quantify exposure burden. My goal is to look at whether high anticholinergic exposure burden is associated with acute brain dysfunction. And specifically, I'm going to look at late onset acute brain dysfunction. So going back to that first study I showed you where I have data that suggests that late onset acute brain dysfunction is associated with worse outcomes. This is my way to evaluate that, but also to evaluate for potential modifiable risk factors for late onset acute brain dysfunction. So that you know, 1/3 of patients that have acute brain dysfunction actually have late onset acute brain dysfunction. I'm going to walk you through some interesting preliminary data. So I have dichotomized the exposure of anticholinergic burden as either high or low. For this preliminary data, I'm actually only looking at day one, so the day of sepsis, the first day of sepsis, anticholinergic exposure. A high score is an ADS score greater than 3. This is based on what has been previously published in the literature as being a high score. In this first part of the table, I evaluated the proportion of patients who developed late onset acute brain dysfunction. So again, acute brain dysfunction that occurs after the first day of sepsis. And as you can see, there's a higher proportion of patients with late onset acute brain dysfunction who have a high anticholinergic exposure on day one. So 11% versus 8%. Now we're going to look just at mortality. Again, we see that there's a higher proportion of patients with mortality who die, who have high anticholinergic exposure compared to those who have low anticholinergic exposure, about 11% to 6%. And finally, when we take into account both late onset acute brain dysfunction as well as mortality, you can see that the mortality is highest for patients who have late onset acute brain dysfunction, irrespective of whether or not they had high or low ADS or ADS exposure. So, right, 12 and 16. But when we account for high anticholinergic drug exposure, those patients had the highest mortality, with mortality at 16%. This is important preliminary data. This data suggests that we may be able to modify our medication exposures as we treat our sepsis patients and reduce both the risk for acute brain dysfunction as well as our poor outcomes. This may change how we treat our patients with sepsis. All right, we're coming to the end. Sorry, I talked a little bit fast, but I hope by now that I have convinced you of the importance of studying acute brain dysfunction and sepsis. But really, this is just a small subset of the acute brain dysfunction or acquired brain injury that we see in critical illness. In fact, acquired brain injury occurs in over 60% of all mortalities that we see in the PICU. Therefore, acquired brain injury is really important that we study in critical illness in general. It's imperative that we identify the patients that are at highest risk and that we provide recommendations for how to best prevent, identify, and treat acquired brain injury or dysfunction. Once I get through my work with sepsis, I actually hope to transition to other patient populations, starting first with respiratory failure or acute respiratory distress syndrome patients. But this is really just skimming the surface. There's many important populations that are affected by acquired brain injury that we can have an impact on for studying. I'm excited to share that I'm actually currently working with Greg Barron as well as many others from the ARCUS team to create an acute brain dysfunction in pediatric sepsis cohort. And so this will be available in the cohort discoveries tool. So if you're interested in potentially studying acute brain dysfunction, the cohort will be there and available. So there's many people that I would like to thank and who have helped me be successful with this work. Obviously, I'd like to thank Jeff as well as Marianne, who supported me through letting me take my idea and run with it and allowing me to validate and study this acute brain dysfunction phenotype. Greg Barron, who's obviously been a great partner and making sure that I always have all the data that I need. I had a lot of one-on-ones with both Joy Patton and Rose Hartman, who spent several sessions with me so I can learn more about data manipulation and coding issues I was having, as well as interfacing with both SQL and R. And then from the Division of Critical Care Medicine, I would really like to thank Alexis Topshin and Julie Fitzgerald, who are my primary mentors. And we have some wonderful research coordinators and assistants who make sure that I get my patients enrolled in my prospective study. But a shout out goes to Sean Dickey, who has really been my lead research assistant for my prospective study, and it would not be a success without him. Lastly, I'm really thankful for the mentorship I've had from Fran Balamuth and Scott Weiss. And there's many members of my K23 committee. So thank you, and I'll take any questions.
Thanks so much, Alicia. That was wonderful. Really appreciate the thoroughness with which you treated the topic. So if everybody would go to the react emoji, and a lot of people are already doing it, throw up some clapping hands. I see a heart. That's great. There are a couple of questions that are in the chat that I'll start with.
Okay.
And I'll attempt to combine them to it. They're from Caroline Diorio and Charles Phillips. So Caroline says, in general, for special populations, how do you deal with a niche issue like olanzapine as a trigger for a patient getting nausea? But then Charles also asks, in the same vein, if you have a significant comorbidity like cancer, could that affect how the patients are bucketed into different groups? Hopefully I did a decent job of restating.
Hi, both of you. I mean, obviously our immunosuppressed population is a important one to consider here, and that's where my work with transplant really started, was thinking about, they have significant risk factors for brain dysfunction, taking sepsis out of the picture. And so we do, I'm sorry, Charles, I don't off the top of my head remember how many kids are in the cohort that have an immunosuppression or oncological diagnosis, but there's obviously a significant portion of them there. Right now, I think because our cohort is so large, and we're actually able to capture a lot of that data, and we are able to actually still evaluate them in the same kind of way that I'm evaluating everyone. I will tell you that when we look at why we maybe had some false negatives or false positives, it's really your oncological patients that we sometimes have a false positive for, because you have a scan to look for CNS disease. However, even accounting for those, because I did have some of them in my reference cohort, we still perform pretty well. I think if we were to take this specifically to look just at the oncological population, we potentially would have a lower sensitivity. In fact, the sensitivity was lower in the transplant population. Then Caroline, to talk about
look in those populations and just like make a 2.0 just for us.
I can take you up on that. We can work together. And thank you, Brad. Yes, as he's mentioning, there's a large proportion of our patients that are immunocompromised. And then for the olanzapine, Caroline, so one way that I at least accounted for this was making sure that I did not include children who were on those medications prior to coming in. And so there's, in part of my code, you actually cannot have received that medication when you first started. So that's how I accounted for home medications. It's hard to account for home medications accurately. Only about 8% of patients actually met the criteria because of antipsychotic medications. And I think it's because I was able to take them out.
Thank you.
You're welcome.
You good, Charles? You're welcome to come off mute if you want to clarify or follow up.
No, I think that's great, and really good talk, Alicia. And one of the things I think for our folks that potentially make them even more confounding, even within the immune compromised, right, is that things like a cranial radiation or that sort of thing, they'll be potentially tough to capture in the data, makes them a moving target, right? They probably have a neurologic comorbidity within the weeks to about a month after radiation, and then they wouldn't. And so depending on the timing of when they got sick, could fall out in different buckets of some of the groups that you presented. But great talk. I think it's really interesting work.
Thank you.
And Charles, just as a thank you, you pointed out in the chat that the tumor registries database is included in ARCIS as in a way, a reference cohort, or at least a grouping of patients. So thank you. I saw a hand go up a little bit ago, and then it went back down. Unless I'm missing something. There was another question.
It was me, Jeff. It's Donna. I accidentally hit the hand button instead of the clap
Oh,
button.
okay. All right, great. Any other questions? Okay. I think Alicia, you did a great job of presenting a ton of work, and I'd like to also thank you for highlighting what the ARCIS program is able to provide investigators at any stage in their career, but in particular junior investigators, trainees. I don't want to say junior. I try to use less earlier career investigators. And trainees, and encourage people to reach out to us. There's a monthly ARCIS 101 session, and also encourage folks to reach out to Alicia. Caroline, I'm glad you brought up the potential collaboration there. As you've seen in this study, we're building on prior art. The sepsis computed phenotype sepsis cohort led in large part to Alicia's work being feasible in a short amount of time. And again, I don't want to minimize it in terms of the amount of time and effort you put into it. I also want to congratulate Alicia on being open to some pretty hardcore technical education and training in how to actually work with the tools that are required to use this data. And we have an education team that is dedicated to supporting you folks, investigators, in that endeavor as well. So that's enough plugging. Thank you for indulging me on that. But if there aren't any other questions, we can wrap up. Last chance. All right. Again, everybody send virtual applause and thankful vibes to Alicia through Microsoft Teams. And this was a great talk, and I want to thank you so much, Alicia, for your time and energy presenting to us today.
Thanks, Jeff, again for inviting me.
All right. Any wrap up that we need to do, Ari?
Nope, that's it.
All right,
Thank you,
that's it.
Alicia.